Today's video we are going to discuss cyclosporine. Cyclosporine is given at the dose of 2.5 mg to 5 mg per kg body weight. Now you have to do serum creatinine. It causes renal dysfunction, so you have to do serum creatinine every week for first 2 weeks and then every month. Now if creatinine is raised, then you have to see if it is raised less than 25% of the baseline, you can continue with the same cyclosporine dosage. But if it raises to more than 25% above baseline, then you have to reduce the dose by 25 to 50%. And you can also you have to give around 1 mg per kg. You have to decrease the dose by 25 to 50%. If any point in treatment creatinine raises by more than 50%, you have to immediately stop cyclosporine. You have to also keep in mind that the creatinine should be raised because of cyclosporine only, and there should not be any concurrent illness. The patient should be drinking enough water, and there should not be any other medicine that is causing the renal failure. If cyclosporine can also cause hypertension, if BP raises to more than 140/90, you can continue cyclosporine, but you have to repeat the BP after 2 weeks. Now you have to add antihypertensive if it stays the same. Now you can add verapamil, diltiazem, but they can cause enzyme inhibition. So you can add isapridine. CCBs and beta blockers are the preferred drugs because the risk of enzyme interaction, hyperkalemia is less, hyperuricemia is less. The drug in itself is said to cause these complications, so if you give CCBs and beta blockers, the risk is less. Isadapradine is a drug which causes no gingival hyperplasia. Gingival hyperplasia is also seen with cyclosporine, so these are the preferred medicines with cyclosporine. Now if hypertension persists, you have to decrease the dose of cyclosporine by 25 to 50%. It causes headache in patients receiving more than 2.5 mg per kg body weight. PCM, NSAIDs, opioids, propranolol are given. Dyslipidemia is said when triglycerides are above 750, cholesterol is above 300. Normal levels are given on your screen. Now first thing to do is diet modification. You decrease sugar and alcohol, you increase the exercise. Diet should cut in your diet you should take less than 200 milligram per deciliter of cholesterol, less than 7% saturated fatty acids. Total fat should be less, but if cholesterol stays consistently high, you can add statins or ezetimibe. If triglycerides are raised, then you add fibrates. Cyclosporine is known inhibitor of CYP3A4, so you have to avoid Simva, Atorva, Lovastatin. You can use Prava, Pitava, and Fluvastatin and Rosuvastatin. Rosuvastatin is also known to cause rhabdomyolysis. Cyclosporine causes hirsutism, but it resolves on termination of therapy. Hair trimming can be done by shaving, plucking, depilatory creams. Paresthesia, hyperesthesia can be seen. So you have to correct electrolyte imbalance if that is seen. You have to see that the patient is not on high dose steroids. You have to correct if severe neuropathy is there, then carbamazepine or gabapentin might be added. Gum bleeding and gingival hyperplasia can be seen. So you have to practice oral hygiene. You have to practice tooth cleaning, scaling, root surface instrumentation. It resolves 1 to 2 months after stopping of the treatment. If it is severe, then gingivectomy can be done. Azithromycin, roxithromycin, and hygiene measures can be taken. Hyperbilirubinemia is seen with UDCA. Now, skin malignancies can be seen, especially if cyclosporine is used with PUVA. Hypomagnesemia, hyperkalemia can be seen. Hypomagnesemia is not seen until 4 weeks. Magnesium oxide, magnesium lactate, magnesium chloride can be given if it is seen. Hyperkalemia can also be managed by dietary modification. Hyperuricemia and gout can be managed by purine restriction in diet or uricosuric drugs, xanthine oxidase inhibitors. Probenecid can be given, it inhibits the resorption of uric acid. Now allopurinol, febuxostat, and NSAIDs can be given to manage hyperuricemia and gout. Influenza-like symptoms can be managed by NSAIDs, macrolides, fluoroquinolones, penicillin. These are some monitoring guidelines according to AAD, European guidelines, and British NICE guidelines. You can take a screenshot of this. Similarly, these are the things that you have to monitor before initiating cyclosporine: blood pressure, creatinine, BUN, CBC, magnesium, urine analysis, urine sediment, uric acid, lipid panel, hepatic function, and urine pregnancy. Now, indications and contraindications: severe psoriasis. We all know the indications. The contraindication is hypertension, renal impairment, malignancy, excessive photochemotherapy, radiotherapy, etc. Now with cyclosporine, you have to maintain it, but there is a transition phase. After clearing of the disease, you have to transit. You cannot give cyclosporine for more than a year or two, so you have to add another medicine. So that is called the transition phase, where cyclosporine is also going on and the another drug is added at a low dose. Then in maintenance phase, you try to taper off cyclosporine and you try to raise the dose of the other medicine. So these were some of the things that you have to remember about cyclosporine. Its mechanism of action is via the T cell receptor. Second messenger is calcineurin. IL-2 attaches to the T cell receptor. You can either see, for inflammation you can either block IL-2 receptors, or you can block T cell receptor, which is attached to the CD3 and CD4 molecule. So downstream signaling molecule is calcineurin. Cyclosporine will inhibit that.